My name is Mike Sabiro. I'm an internist at WakeMed Gardner Primary Care, and we are going to discuss today an evidence-based approach to controlling type 2 diabetes. The real focus of today's discussion, however, is on poorly controlled diabetics, specifically patients with A1Cs of greater than 9 to 10, and how to get those patients under control. As most of you know, the incidence of diabetes is increasing and the incidence of poor control is increasing. This has become largely a primary care problem that we as primary care practitioners need to deal with. There are more treatments available now than there have ever been, but these treatments have not necessarily led to better control. However, used correctly, I think they can really help us get the refractory patients under control. The first point to make is who is poorly controlled, and I would put that largely into three groups. The first group is patients who are non-compliant. This is clearly not a discussion of compliance, but I would recommend to pick your spots to see if other entities can affect change in the behavior and compliance of your diabetic patients, such as diabetic educators, using your staff, using your nurse, and to keep trying. I believe that diabetes education helps everyone, whether poorly controlled or well controlled. The second general group are insulin-deficient patients. These are patients with type 1 physiology, and oftentimes they're older and thinner patients who've become primarily insulin deficient. These patients' control will be improved by intensifying insulin, and I'm going to discuss that to a greater extent later in the talk. Next slide. The third group are the largest group here, I think, which are the patients who are both insulin resistant and insulin deficient patients. These are patients who have been managed with orals and have become uncontrolled, or have been managed with large amounts of insulin and still remain uncontrolled. And I want to focus on this group first. This is the ADA guideline slide, and it shows the benefit of combined treatments of this type of patient. And if we look to the right side of the slide, that's where we go for controlling patients who are not well controlled and who need a more aggressive regimen. The ADA, if you look, would recommend metformin first, and then they recommend second-line agents, and they differentiate the agents by their efficacy, by their risks, and by their cost. Again, if you look to the right side of the slide, they talk about adding GLP-1 receptor agonists and basal insulin to metformin. For our poorly controlled patients, I think this is where we go, and we have to be aggressive here. So we can add basal insulin to metformin, we can add a GLP-1 agonist to metformin, and if that combination doesn't work, then we can add both of those to metformin. And I've seen the greatest efficacy with that type of combination, specifically in patients who are both insulin resistant and insulin deficient. If you look down under triple therapy, it also tells you that you can combine multiple agents. So metformin, GLP-1 agonist, basal insulin, TZDs, SGLT2 inhibitors, DPP-4 inhibitors, which are a little bit less efficacious than the others that are mentioned. But again, to control these patients who are usually obese and are both resistant and deficient, I think we need combinations like that. If you look all the way to the bottom, the ADA and also the ACE, which we'll talk about later, recommends using a combination of basal insulin or mealtime insulin or a GLP-1 agonist in place of mealtime insulin to control those patients who are refractory to the combinations mentioned above. And this is an important point. Using metformin and a GLP-1 agonist along with basal insulin can be just as efficacious, if not more efficacious, than using a basal insulin mealtime insulin combination, especially in patients who are very insulin resistant. Next slide. This is a slide of the ominous octet, and I believe that if we understand the underlying pathophysiology of diabetes, it leads us to a better and more focused treatment choices for our patients. So the factors here are the main factors that underlie type 2 diabetes: decreased insulin secretion, increased glucagon secretion, decreased glucose uptake, which is the main driver of insulin resistance, increased glucose resorption from the kidney, decreased incretin effect, increased lipolysis. And again, if we look at all the factors and say, okay, what drug classes affect these factors, I think we can get a better idea on what's going to help our patients the most, specifically those who are both resistant and deficient. So as you can see, GLP-1 agonists affect a number of different parts of this ominous octet. TZDs affect a number of different parts of this ominous octet. TZDs seem to have been lost lately after some questionable studies, but for patients who tolerate them and can take TZDs, they can be very helpful with insulin resistance. And if you look at that decreased glucose uptake part, that's peripheral insulin resistance. TZDs and GLP-1s can make a big difference there. And those are drugs that, in addition to basal insulin and metformin, can help people get well controlled. So my point here is to make sure you're treating the entirety of the pathophysiologic process to get improved control in refractory patients. The last point is increased glucose resorption in the kidney. It's not placed on the slide, but the only group of medications that affects that glucose resorption are SGLT2 inhibitors. And sometimes the addition of an SGLT2 inhibitor can make a huge difference when other agents aren't controlling type 2 diabetes. Next slide. These are the ACE guidelines, which is the American Association of Clinical Endocrinologists, and they really build on the ADA guidelines. And I put them in there just to focus on one thing. If you look at triple therapy, their guidelines are very similar to ADA, but they list a hierarchy based on the agents that they think are helpful in controlling people. So they recommend metformin first, GLP-1 agonist second, SGLT2 inhibitors third, TZDs fourth, basal insulin fifth. Those are sort of the things that I've been focusing on in this discussion, and that's their hierarchy of use. And in addition, they talk about what ADA does also, where adding metformin plus GLP-1 plus basal insulin can be as effective, if not more effective, than basal bolus insulin in patients who are both resistant and deficient. Next slide. Now, when we use insulin, first of all, at the top, basal insulin. When we choose to add basal insulin, there are a number of different basal insulins that can be used. I start typically with 10 units of basal insulin, but I have the patient self-titrate aggressively at home. And I think this is a key point. If we let the patient self-titrate, we can get people under control much quicker, and I think that patients take more ownership of it. So with basal insulins like Lantus, Levemir, Toujeo, I have them increase by 3 units every 3 days until their fasting sugar comes to the goal that I set, which is typically 90 to 120. With Tresiba, because it's longer acting, I'll have them increase 4 units every 4 days. And I keep adjusting basal insulin upward until I get to a fasting goal. Now, for patients who definitely need mealtime insulin, they've failed basal insulin oral combination, or they're the patients I mentioned before who are clearly insulin deficient, patients with type 1 physiology, older patients who are thinner, I would move to the left of this chart and add 1 rapid-acting insulin injection before the largest meal. So that's Novolog, Humalog, Apidra. I would typically start with 4 units with the largest meal, and there's a study called Full Step which suggests that we should increase by 1 unit a day until the postprandial sugar comes under control. So, for example, if you add 4 units at supper time, you have the patient check a 2-hour after-supper sugar every day. You might set that goal to be 100 to 150, and you have the patient increase that prandial insulin the following day by 1 unit every day progressively until that prandial sugar gets under control. If adding prandial insulin with 1 meal doesn't get people controlled, then I would add it with 2 meals, and that goes to the bottom of the chart. So you add a prandial insulin injection with the biggest meal and with the second largest meal, and you titrate just as I mentioned earlier. Moving over to the left side of the chart, talking about premixed insulin. But the most important part about premixed insulin is there are patients who can't afford some of these expensive therapies, and premixed insulin remains relatively inexpensive. So this is typically when I go to premixed insulin twice a day, when you can use a generic 70/30 insulin, and I typically give it at the beginning of breakfast and supper. If I'm switching from other insulin, I will try to approximate the dose. If I'm starting de novo with somebody who's poorly controlled, then I might start with 10 units with breakfast and 10 units with supper. With this insulin, I'm a little less aggressive about titration. I tend not to have patients self-titrate it because there's a much higher risk of hypoglycemia with premixed insulin. So I might start with 10 twice a day, bring the patient back, see where their sugars are. I typically base my morning dose on their pre-supper sugar and my supper time dose on their pre-morning sugar. It's important to note that we should aim for fair, not excellent control with premixed insulin because we want to avoid hypoglycemia. I still think we can get people well below an A1c goal of 9 with premixed insulin. Another important note is I think when you're using insulin of any kind, you should get rid of the sulfonylurea. I think the combination of insulin and sulfonylurea increases hypoglycemia risk significantly. I think basal insulin alone without sulfonylurea has a pretty low risk of hypoglycemia, and that's why I think you can titrate more aggressively with that regimen. Next slide. The final point to make is that WKCC Care Advising is getting involved with diabetes A1c control. Care advisors are working to engage all commercial diabetic patients with an A1c of greater than 12 in a diabetes program called Condition Care. The goal of that initiative is to improve planning and coordination between the care advisor and the primary care provider and increase the likelihood of good outcome with respect to diabetes. So this is not going to get all your patients who are 9 or 10 and above, but it will help with the patients who are greater than 12 and above, and hopefully the care advisor can be part of your armamentarium in treating those patients. In summary, I hope I gave you a few strategies to help with controlling those patients who are poorly controlled. I would always be happy to answer any questions that any of you have. Thank you very much for attending.